installment of the new format here. Now, hopefully I can get this up on your thing. Okay, well, it's on my thing, but it's not on your thing. It should automatically come up on the projector.
Just make sure.
Well, how many computers do you get to use? There you go. Okay.
There's a mic there for you because I'm important. You can't hear it, it's still recording. It's all on, ready to go.
Is it? Okay. All right, so what we're going to do is this is going to be the first installment. Every month you will get a case. You put it in your book and you answer the questions and I review the book. It goes towards your certification grade, pass, fail, whatever you want to call it. Yeah, because it's going to be collected sometime this month by Greg so that I can have an opportunity to review it. And each month is a case. So the first thing we'll do is present the new case. We'll talk about the old case. We don't have one this month. And then we'll do a quiz session where I will call your names off the roster, which, Greg, I need the roster. And you will come up and answer the questions that I'm going to give you, which have nothing to do with the case. They're going to be physiology questions, anatomy questions, medical questions, so that you get used to thinking on your feet and being able to talk in front of a group. It's important that you understand it's a training exercise. You're all used to training exercises. I'm not doing it to embarrass you or to make you look bad. You got to be able to function in front of people with criticism. Got to be able to do it. It's part of your job. I got to do it every day that I work, including when I teach. So, therefore, we're going to be doing that, and then the next part will be every month. Two of you will give a short 10-minute presentation on a medical topic related to pre-hospital care. No fire topics. They have to be medical. You have to be prepared. I'm just going to call your name off the roster starting next month. If you don't have the PowerPoint prepared to give, you're not going to get certified. So that gives you a month to prepare whatever it is you're going to talk about. You can talk to Greg and discuss the topic with him and see if it's okay with him. I don't want it super detailed. You only have 10 minutes. So that means you're going to have maybe 5 slides. Okay, you're not going to be able to do something that's really in depth. And that's not what I'm looking for. Again, it goes back to you being able to perform in front of people and be able to control your anxiety. It's important to be able to do that. Because in the field, that's what you got to do. And then the last thing I'll do is probably, I've given this a lot of thought, talked to a lot of the other trainers in the various agencies, a lot of the EMS trainers. And it seems that the overwhelming theme or problem that they identify is the lack of understanding of the anatomy and physiology of the human body. So what we're going to do is we're going to discuss mostly physiology for the next few months. Okay? That way you get a better understanding of how the body works. It helps you in determining the disease processes and figuring things out, and in figuring out how drugs work, because that's important. You have to know that. This is all in order to increase your knowledge and your proficiency and your ability to handle any kind of case, especially in the face of this pending transport initiative. Any questions so far? Okay, it's your first case for January. Everything I give you are real cases, and I know the outcomes. So, here's a case, not local. I won't give you anything local. 45-year-old male, MVC, car versus tree, unconscious at the scene. So write that in your book, and then write the questions underneath it. What's your differential? What do you need to do on arrival? This is the only call you got. It's the only information you got. This is the way I ask you in your certification exam when I test you. So I need to know what you're thinking. What kind of injuries is he going to have crashing into a tree? And what determination do you need to do when you get there on this individual? So think of your basic stuff, your history and physical, your scene evaluation. Are there any witnesses? Law enforcement's probably there. Those are the things that you need to think about. Everybody got that? Anybody need more time? Okay, so on the scene, you notice the patient does not have any seat belt. He's got extensive damage to the driver's side, and he's unconscious. Do you call a trauma alert? Why or why not? No, don't answer the questions. Okay? You're going to write them in your book, and I'm going to look at them, and we'll discuss it next month. Today, you're just taking down the information. When you answer the questions, you can do it in narrative if you want. You can do it in a list, whatever is easier for you to remember. I don't know if this works. I put a battery in it, but it wasn't working right. Everybody got it? You notice the patient has agonal respirations and is unconscious, but he has a good blood pressure and pulse. Questions: how do you manage the airway? Give the reasons for each of these things. Do you intubate him, RSI him, bag him? I didn't put in a king tube airway, because where this happened, they don't use king tubes, they use combi tubes. And you'll give me a discussion as to why you would or wouldn't do any of those things. No, you don't need to even know that information. He has an airway problem. What are you going to do for him? You have a man versus tree who's unconscious with agonal respirations. What more do you need to know to manage his neck? You can't answer any questions.
What if his neck's broken?
Well, are you going to manage his neck by not managing his neck? What do you need to know about his neck?
What if he's got trauma?
What do you do in a guy that crashed into a tree and is unconscious and having agonal respirations? Do you not immobilize his neck?
Yeah, you're going to do a rapid X and you're going to handle it.
Okay, you don't need any other information. You need to know what to do. You should know this already. This is the information you get. This is what EMS had on the scene. So after they did their treatment, patient arrested and died in a local hospital because of treatment rendered at the scene and lack of adequate evaluation. No physical was done. Patient was not undressed. His chest was not examined. Nobody saw one of his pupils was blown. And what they did to manage his airway killed him. The information they got is the same thing you got, other than the fact that they were supposed to examine the patient. Okay? Greg, did you say you had a list?
Yeah.
Well, unfortunately, it's going to be hard to reach that board. So I guess we're going to have to use this little thing here.
That should be a fresh page. All the markers are right by your,
Oh, yeah, I see 'em. Okay. Bruce Sheffield. Come up here and give me 10 diagnoses that are associated with shortness of breath. Write them on this piece of paper. Give me 10 things that cause shortness of breath. It's the only information you have, shortness of breath.
Related to trauma?
No. The case has nothing to do with what we're going to talk about. Remember, 80% of what we deal with is medical, so. It just happens this trauma case had an unfortunate outcome and was directly related to the pre-hospital care. Ten things that cause shortness of breath. Write as many as you can think of. If you can't get 10, then Jimmy Zamora is going to finish your list. What are they doing next door? BLS? All right, Jimmy, come up here and help Bruce. He's stuck on 2. Need at least 10 up there. Oh, all right, yeah, that would help.
Yeah, I just thought.
Yeah, because it doesn't say what they are, so. Okay, Bruce, you guys have to put down who's the paramedics and who's the EMTs. I'm not saying that EMTs get a pass, but you're still going to be tested with this stuff. But in any event, Bruce, you can sit down. All right, Jimmy, go ahead, finish it off. Oops.
I don't know if I want to.
Remember, guys, this is a training exercise. I don't use this to grade you or certify you, but this is how I test, and you need to be able to do this. You need to be able to think this way on your feet outside of the department when you're on your calls. How many do you have there, Jimmy?
Got 9.
9? Okay. Okay, Brad Brown, come up here and differentiate the findings in CHF and emphysema. That's all right. You don't write any worse than I do, that's for sure. CHF and emphysema. Compare and contrast, and you can flip the page over and write on. It's probably easier to do that because I'm going to flip that page back again. So yeah, just flip that one over and put CHF on one side and emphysema on the other, and then tell me the differences historically and physically on exam. That way we have a comparison of the two illnesses, because you're going to see a lot of that with this population. Tom Harrison, come up and do emphysema for Brad. Brad, you just do CHF. Put down the pluses and minuses of what you see on exam. And Tom, do the same thing with COPD. The things are over there on the table. While they're writing that, think in your head what it is you're going to see on exam.
You just want what we see on exam?
Well, you know, what would you expect from the history? What would the exam tell you? Because then the next two guys that come up are going to tell us what they mean, what those findings mean physiologically. And then try to think of as many things as you can that you actually use in the field. You know, this is all practical application of your knowledge. That's what we're trying to do. They call this in school critical thinking, but what we call it is practical application of your knowledge. So. When you guys are done, just turn around and we'll look at what you wrote. Okay, so let's see. CHF, usually a cardiac history, lung sounds, the muffled heart. I couldn't read that last thing. It says lung sounds. What's next? Wet. Okay. Muffled heart sounds for CHF. Edema. Where?
Extremities.
Okay. Shortness of breath. Decreased SATs. O2, what do you mean by that?
O2 sats down.
Oh, O2 SATs, okay. And then blood pressure down, heart rate up. Okay. So, yeah, it depends on where you are in the cycle, but that's fine. You can put, you know, when you want to say blood pressure is either up or down, you just put plus minus, and that generally is accepted as it can be high or low, depending on where you are in the physiologic sequence of the heart failure. Okay. Tom, you have lung sounds. What do you mean by that?
You'd obviously listen to their lungs and they're probably diminished.
Okay, so one of the hallmarks for, let's talk about lung sounds a minute, because one of the hallmarks for lung sounds in patients with COPD or emphysema is called a prolonged expiratory phase. Okay, guys? What does that mean? It means it takes them longer to exhale than it does to inhale. Okay? So when you say lung sounds, that's one of the things you should be looking at with these people that should click in your head. Okay? Yeah, and they may be diminished. Okay, so you have previous history, good. Inhaler use. Questionable smoker or smoking history would be fine. So yeah, pretty much for your purposes clinically, COPD and emphysema are the same kind of thing. Just in your mind, if you think of it the same way, it doesn't get confusing. All right, guys, good, sit down. Brad, flip the first page back for me. Okay. Ray, explain to me how CHF causes shortness of breath. Yeah, go up there and put down what it is in the physiologic makeup of CHF that makes you short of breath. You know, Greg, I'm going to drop this thing on the floor.
CHF, basically, your heart is not extracting fluid out of your lungs. It also, basically, your lungs start filling up with fluid. Basically, you got more pressure in your vascular system than it is in your pulmonary system, which is why CPAP works. The way I would treat it is I would give CPAP. Right? What CPAP does is that since you have positive pressure of oxygen going straight into your lungs, it kind of balances out the pressure in your pulmonary system to your vascular system, therefore pushing the fluid back into your system. So basically, as we know in CHF, one side of the heart, one or the other, is working less than the other. So basically, that's why we see edema. We all know as medics and as EMTs that when you see edema, it means that your right side of your heart is not working adequately enough to actually bring up the fluid from your legs. Now in CHF, on your lungs, when you have rails, of course, obviously it's your left side of the heart, and actually you got more pressure on your right side of the heart pumping into your lungs than on your left side of your heart pumping it out of your lungs. So therefore, that's why CPAP is so effective. It actually tries to more or less, if you think of CHF more as a pressure problem than as a respiratory problem, and you're trying to equalize that pressure, then you'll understand it a whole lot better. So therefore, that's why CPAP is then again effective in CHF. It's actually pushing that fluid back into your system by increasing the pressure in the pulmonary system.
Good job, Ray. You guys understand that? I mean, that's a very basic physiologic response that you need to understand and why certain things work. One of the complications of CPAP is a blood pressure response. Mike Mendez, does the blood pressure go up or down in CPAP? Yeah. It was a 50-50 chance. And you got it wrong. But that's okay, because this is a teaching experience, a teaching lesson. All right, what happens is the blood pressure drops in CPAP, okay? Now, it depends actually more on the ventilated patient who's intubated than on most of the CPAP we see with a mask. Why is that? The reality of it is, even though we think we get a good seal with a mask, I mean, there's still leaks. So that you don't have quite as bad of a problem with BP drop. But you guys need to understand that if you put a patient on CPAP and you check their vitals and their blood pressure is 80, more than likely it's from the CPAP, okay? If you tube them and put them on CPAP, definitely it's from the CPAP. So that's one of the negatives. Even at just 5 millimeters of pressure, their blood pressure can drop as much as 25 to 30 points. So it's got to be something that you're thinking about, okay? I'm not telling you it's going to happen every time, because as I qualified that, remember, the mask isn't not really a perfect seal, okay?
Isn't that a good thing, though? A lot of times CHF patients have really high pressure.
That's fine if their pressure's high, yeah. But if their pressure's 100 because they're in stage 4 of pulmonary edema or CHF, and now you're dropping it to 80, what's going to happen? Yeah. They're not going to get any perfusion.
So why does it drop then when you're doing CPAP?
It's because of the pressure against the vessels and the heart, okay? It causes that paradoxical response and drops the blood pressure. But it'll come back up if you relieve some of that pressure against the heart.
If it doesn't come back up with dopamine, it'll probably be our next route. You don't want to fill them up with fluid already.
No, you have to be very careful because you're on a very tenuous balance. Remember, when you get a patient that's in stage 4, and there's 4 stages of congestive heart failure / pulmonary edema, it was written many years ago. They don't talk about it much anymore, but it's something that helps you when you manage a patient, especially if you're pretty far from the hospital. You know, all the agencies that are 20 minutes away from a hospital, 30 minutes away, you guys have to know what to do with those patients. So, if you have a patient whose pressure is low, you have 2 options actually three options, but one of them we don't do too much because the patients are usually too acidotic. You can give them fluid, which may make them worse. You can give them Lasix, which we really don't do a whole lot, because why? Well, we don't carry it, but why don't we use it? Okay, and what's the other problem with it? Why does it take a long time? What happens in most of these medical conditions?
Everything's shut down. It has to go through the renal.
Okay, but why does that happen? What is the basic problem with the acid-base balance? Remember, we talked about this. What happens in these conditions? When patients get very sick, whether it's pneumonia, CH, it doesn't matter what it is, what happens to the body's chemistry? Is it alkalotic or acidotic? It's acidotic, right? What happens in acidosis physiologically? You don't get the perfusion. The kidneys shut down. It tries to buffer your body's pH to bring the pH back up to a normal level. It can't do it. We have two mechanisms, remember, that we use, that the body uses. One is pulmonary, the lungs, and one is renal. And remember what we said about this? Renal is more responsive in terms of actually fixing the problem, but it's slower onset. Pulmonary is quicker, but it's very incomplete. Okay? So you can only buffer a small amount of acid through the lungs, and as your body tries to make you hyperventilate and blow off your CO2. Now, the third way of dealing it is with a pressor. What happens with pressors? I don't care what you use, norepinephrine, dopamine, dobutamine. What does a pressor actually do to the vessels? It closes them up. What do you think is going to happen to perfusion through the kidneys? You think it's going to make the situation worse? So over time, it can make it worse. So that's why you're walking a fine line managing these people's fluid balance. Now, understandably, pre-hospitally, it's not that big of an issue for you because you're just getting the patient, and just giving them oxygen is going to have a positive benefit. However, if you have somebody and you're pretty far away and you got to, travel into a hospital somewhere, you're going to need to know what's the sequence of events that's going to happen to these people. Okay, you need to know that, so you need to know what to do. You know that you don't carry Lasix. EMS took it off the rigs. Why? Who the hell knows? I have no idea. But I understand the physiology, so it doesn't really work acutely. What else can you use that you carry that might help? What was that? Bicarb. What else? Okay. That's thinking the physiologic response of the patient. What else do you have? Oxygen. Okay. You can give them oxygen. You can hyperventilate them. If you tube them, oh my God, did we say tube? It's funny because, I work in other counties, and medics in those counties intubate patients all the time, even dead ones, cardiac arrest patients. So, my issue has always been, how are you going to be any good at tubing a patient if you don't do the dead ones? But until I'm the medical director for EMS, I guess it's going to stay that way. And God knows that'll never happen. Okay, so we were talking about the ways of treating these CHF patients and what's in your armamentarium. You have nitrates you can use, provided the pressure's not too low. If you give somebody nitrates and their pressure drops, what do you do? Do you give them a pressor, or do you give them fluid? Fluid. You give them some fluid. Even if they have a little CHF, you can still give them some fluid. Okay, it's the safest thing to do. Why? Because you can usually get the fluid off them, and you can always oxygenate them. Okay, let's see. Who do I have left here? Fred. Give me the clinical findings of attention pneumo. Come up here and write them down.